بسم الله الرحمن الرحيم. اهلا بحضراتكم النهارده الفورث ويبينار series of webinars الحقيقه based on the position statement of the Egyptian Society of Cardiology. احنا زي ما حضراتكم جزء من حضراتكم سمعنا قبل كده بنتكلم على مجموعه من الويبينارز based على ان احنا كنا عايزين في جمعيه القلب المصريه نبعت رساله ازاي ان احنا نقدم خدمه معقولة لمريض القلب في مصر despite ان في pandemic at the same time وفي كتير من المستشفيات وجهت معظم مجهودها ل مواجهة الكوفيد 19. ففي حصل allocation للريسورسز، وفي نفس الوقت واحنا بنقدم الخدمة دي لمريض القلب المصري احنا محتاجين ان احنا to take the utmost care in order not to spread infection لا للميديكال ستاف ولا للمرضى اللي جايين ياخدوا العنايه المطلوبه. وبالتالي هتلاحظوا ان كتير جدا من النون انفيزيف وحتى الانفيزيف انفستيجيشنز وبروسيجرز قلت، والالكتيف بروسيجرز تقريبا اتمنع تماما. النهارده يعني احنا من ضمن السلسله دي الويبينار نمبر 4 بنستضيف الحقيقه يعني one of my dearest friends, one of the experts in the field of heart failure, Professor Hany Sabbour. He is the consultant cardiology and electrophysiology في الشيخ خليفة Medical Center managed by Cleveland Clinic في أبو ظبي في United Arab Emirates. And he is an attending cardiology, EP cardiology associates في Rhode Island, USA, and clinical assistant professor of medicine, Warren Alpert Medicine, Brown University, برضو in USA. الحقيقة he is an expert in both electrophysiology and heart failure، وما تأخرش لما طلبنا منه ان هو الحقيقة يعني يبقى ضيف جمعية القلب المصرية in such a webinar. فاحنا بنرحب طبعا بالدكتور هاني. معانا another يعني expert بروفيسور نبيل فرج، هو اخويا وصديقي العزيز وهو استاذ القلب في كليه الطب جامعه عين شمس، وفي نفس الوقت يعني a great interventional cardiologist. و I think برضو ان الموضوع بتاع الابريلينون النهارده في الهارت فيلير is very important، وبالتالي we are الحقيقه eager to hear from him. هيدير بقى النقاش النهارده صديقي العزيز بروفيسور حسام حسن، استاذ القلب في استاذ ورئيس اسم القلب في كليه الطب جامعه اسيوط، من اصغر مثالي رؤساء الاقسام اللي جم في الجامعات المصريه، وفي نفس الوقت he is board member of the Egyptian Society of Cardiology، وكان قبل كده امين صندوق treasurer of the Egyptian Society of Cardiology، ومقدم الحقيقه اداء رائع في جمعيه القلب المصريه، واسمه منور على البيبر برضو، ساهم في خروج البوزيشن ستيتمنت. وبالتالي ما فيش اقدر من بروفيسور حسام ان هو يقدم السبيكرز ويدير النقاش، وهيبقى فيه كويستشنز من انتراكتيف كويستشنز من الحضور. ارجو الجميع ان هو يساهم، واعتقد ان شاء الله انها هتبقى سهره علميه جميله جدا. حدي الميكروفون دلوقتي بروفيسور حسام حسن، اتفضل.
يعني الحقيقه انا سعيد ان انا موجود النهارده في الويبينار ده مع هذه النخبه من الاساتذه، وطبعا يعني برحب بالدكتور هاني طبعا منضم الينا النهارده، طبعا دكتور نبيل فرج ودكتور سامح، وطبعا بشكر شركه بايو فاكتور على انها تولت تنظيم هذه السلسله من الويبينارز. يمكن النهارده احنا الويبينار هينقسم الى جزئين. الجزء الاولاني هتبقى محاضره الدكتور هاني، وطبعا يليها بعد كده محاضره الاستاذ الدكتور نبيل فرج. هنبدا اول محاضره مع دكتور هاني صبور. دكتور هاني.
تمام.
دكتور هاني هيكلمنا على مانجمنت اوف هارت فيلير في الكوفيد بانديميك.
Thank you very much. يعني it's a great pleasure to be part of this very esteemed group ويعني أشكر دكتور سامح for including me. أنا طبعا I'm an Egyptian. I've been living outside Egypt for a long time, and it's very important for me to try and contribute in some ways to help out even remotely. And thank you for both the chairpersons and my co-speaker for allowing me to have this opportunity. So let me just bring up the slides. So I think one of the most important things, having read your excellent paper on the position statement, is we have to prepare ourselves for what's coming, right? And it's clear that we need to utilize our resources for ICU management, ventilator management, and so on. But at the same time, cardiac patients still need care during COVID-19. And what we have to do as clinicians is really very challenging, because we have to change our mode of practice. We have to think of ways of protecting and taking care of our cardiac patients in as much as possible without exposing them and ourselves to risk. At the same time, we also have to combat a lot of myths and nonsense on the internet and bad media. So one of the most useful things we have found is the application of telemedicine and intensive medical therapy in heart failure and cardiac patients, and overcoming myths with evidence and best practice. And of course, all of you are familiar with the recent retraction of the data from the New England Journal of Medicine on the hydroxychloroquine. So again, you know, this is really very difficult for us to keep up with the positive and negative approaches. These are my disclosures. I actually do have a joint appointment in heart failure and electrophysiology at this point. So first of all, this is one of the challenges we have to deal with. There's a lot of nonsense circulating on the internet, WhatsApp and the social media. So we now have to fight a dual battle, a battle of misinformation and lack of knowledge, and also internally update ourselves and try to keep track with the explosion of information about this horrible disease. I'm sure you've seen all of this, and it's just to highlight, you know, what is the fake news that's around. Now we'll have to deal with some facts. So one, usually, you know, we have to be very proud of our history as Arabs and scholars. Ibn Sina, of course, was the first father of modern medicine, and he wrote the canon of medicine. He actually wrote about disease transmission from human to human by microorganism, and devised this method of isolating sick people for 40 days called al-Arba'iniyya. And this method was taken from Italian traders from Venice, who took it to medieval Italy to treat and quarantine the patients with Black Plague. And in fact, they call it quarantina. In Italian, it means the 40 days. This is the word quarantine. It actually is one of the inventions of Ibn Sina. So we have to be very proud of this. Now, going back to a very similar worldwide pandemic, this is the Spanish flu pandemic of 1918. And in that pandemic, 50 million people died. 50 million, because like this virus, there is no active treatment, but at that time, at this time, we have ways to create life support and support the patients throughout this really fulminant infection. And this is from a small town in British Columbia, and the notice was basically all meetings have to be stopped, everything until further notice. And look at the number here, all public gatherings of 10 or more people are prohibited. And this is a picture from New York City where you see the police in New York City wearing the masks. Universal masking. It's the only solution. And in fact, at that time, this is the law. Wear a mask or go to jail. So this really had to be very heavily enforced. And here's a picture from Columbia University where the nursing staff was conducting their nursing rounds with masks, but you see the social distancing isn't being practiced. So that's another message to remember. And at one point, they actually brought in the US Army to enforce these regulations. So this is serious business, and 100 years ago, they had to do the same things that we're doing right now. Now, the ESC has also come up with a statement. And the statement from the March publication is that the needs of patients with cardiovascular disease cannot be ignored. I'm sure you've seen this parameter. So during the current pandemic, more people will die of cardiovascular disease in total than of COVID-19, because this is continuing in the background. Patients with CVD and risk factors such as hypertension, diabetes, and smokers are more likely to die of COVID-19. Hospital admissions in ACS, you have seen this, they dip, and then all of a sudden you have explosion of patients with STEMIs and acute coronary syndrome, because they've been waiting until they come in with cardiogenic shock. And it's fairly clear that STEMI patients with seeking help much later, and more of them are admitted in more advanced stages of disease. So it's important that the message "don't come to the hospital" does not apply to patients with ACS or acute coronary syndromes and decompensated heart failure. So how do we solve this problem? This is a paradox. We're telling them not to come, but we want to treat them and be aware of them. The other important thing is, of course, the ACE receptor and the COVID-19. I think we're over this, but it started with a letter to the editor talking about the proposed mechanism of ACE inhibition and COVID-19 binding. This, of course, led to a lot of panic among patients, a lot of panic among physicians, and in fact, the take-home message, finally, after several weeks of bargaining back and forth in the literature, there is no data supporting that ACE inhibitor or ARBs facilitate coronavirus entry by increasing ACE expression, and treatment with RAS blockers should not be discontinued because of concerns of coronavirus infection based on current data. And finally, we got a systematic review that was published at the end of March from the Journal of Hypertension, clearly stating that this is a false mechanism, and in fact, patients who are on RAS blockade, it actually increases the soluble ACE2 and in fact provides a decoy to the COVID-19 virus to avoid cell entry. So this whole story that started with a letter to the editor and exploded across the world, really another example of how fake information is now invading medical practice. We have to be very, very careful as we're trying to learn what to do. Now, one important concept that I have to bear in mind before we go into telemedicine is that we have to strategically avoid hospitalization. How can we avoid hospitalization? By basically avoiding decompensation and avoiding heart failure. This is a major objective for our outpatients or those sitting at home during COVID-19. And the only way to do that is to maximize guideline medical therapy. And in fact, I'm going to show you some techniques where you can maximize and up-titrate guideline-directed medical therapy safely and effectively using telemedicine. The guiding principle is to reduce exposure as low as reasonably achievable to COVID-19 patients. So the key is to maximize GDMT. And that's where I started with don't stop RAS blockers. So the COVID-19 guidance from the Canadian Cardiovascular Society actually came out before the American Cardiovascular ACC and before ESC. And it still stands right now. And these points, of course, they're not new, are continue taking the ACE and ARB and ARNI unless the patient has an independent reason to stop it, like conventional problems like hyperkalemia or hypotension. Aspirin, not to stop aspirin, and patients on low-dose aspirin should not be interrupted. This is really important. And the only thing that they put in was that non-steroidals may not be of use and may have some harm. In any case, there are alternative therapies like paracetamol. So just to jump into heart failure, now we just have to remember that clinicians have noticed that the syndrome of heart failure is going on for centuries, right? And in fact, it was written in the Ebers Papyrus, which was from the ancient Egyptians. So I think it's important to realize that heart failure is triggered by adrenergic activity and RAS activation. So as we start with the potential for myocardial damage from myocardial infarction or ischemia, we have stroke volume issues, which leads to neurohormonal activation and activation of RAS and sympathetic nervous system. Subsequently, we have counter-regulatory vasoconstriction with increased sympathetic tone and activation of angiotensin II and endothelin, salt and water retention, further ventricular stress, further remodeling. So we're all familiar with this sort of vicious cycle. The renin-aldosterone system in heart failure is the core pharmacological abnormality, which we address by blocking either the angiotensin converting enzyme or angiotensin II, and currently we also have ARNI. In addition, we will also add mineralocorticoid antagonist, which then comprehensively blocks the entire RAS pathway. We also have to address the sympathetic tone as well as salt and water retention with diuretics. Sympathetic activation in heart failure is also caused by myocardial damage. So the stress response is also triggering RAS activation, vasoconstriction, increased contractility, and direct cardiotoxicity, all of which increases ischemic demand, myocyte damage, myocardial wall stress, and hypertrophy. Now this also you're going to see in your COVID-19 patients because they develop this bizarre myocarditis that has no clear explanation, in addition to the pulmonary thromboembolism that's been recently discovered. So going back to the core therapies, so we have reduction of cardiovascular death, with inhibitors of RAS blockers. So from the old captopril studies, the solved treatment arm, and the Atlas studies, ACE inhibitors with ARBs, and then of course the addition of neprilysin inhibition reduced mortality by an additional 20%. If we looked at the combination of ACE inhibitors and beta blockers, and this is very old data, but it's very valuable even today, that the combination of diuretics and digoxin in the solved treatment arm had the worst outcome by adding ACE inhibitor, and this is from 1991, not current data, we'd reduced that by another 3%. By adding beta blockers to the combination with ACE inhibitors, we were able to cut mortality by almost 50%, and this is 1 year mortality. So this is old data, but it still holds true. Now, if we fast forward to 2020, and I borrowed this slide from Professor John McMurray, building on the evidence-based medicine, we have consensus solved in the charm for ACEs and ARBs, central therapy for heart failure, plus beta blockers from CBIS, Merit, and Copernicus. We also have RAILs and Emphasis, which emphasize the role of MRA. So these are the core triple therapies. Additionally, we have ivabradine from SHIFT, neprilysin inhibition, which is Paradigm, and the SGLT2 inhibitors, which has been now recently approved in heart failure with and without diabetes. Now, the noradrenaline component is very important because noradrenaline has direct renin release and stimulates renin-angiotensin-aldosterone system. So it's a co-activation, plus direct triggering of arrhythmias like AFib and ventricular tachycardia, myocardial damage, MVO2 is increased, and vasoconstriction. By doing selective beta blockade, so on this side we have nebivolol, bisoprolol, metoprolol, and also carvedilol, which is an alpha-beta blocker, you're able to block the sympathetic activation and mediate the significant benefit on the beta-1 receptor. There are slight differences, of course, between the two beta blockers. In general, though, beta blockers in heart failure reduce all-cause mortality between 35 and 34%, regardless of the type of beta blocker and regardless of the severity of heart failure. The worst patients, which were studied in Copernicus with a very low ejection fraction, actually did better than the patients with the slightly reduced EF. So it's very important across the range not to stop. And if you make a comparison of bisoprolol and carvedilol, there's actually a difference in terms of bisoprolol in atrial fibrillation than carvedilol, which may be important in terms of rate control and patients with AFib. So at this point, again, I borrow this from a slide from Professor McMurray, ACEs and ARBs are now being replaced by neprilysin inhibition. Beta blockers are essential, MRAs are essential, and of course now in all diabetic patients and in a majority of non-diabetic heart failure patients with HFrEF, SGLT2 inhibitors are essential. Back again to not stopping the RAS blockade. This is not something that is at all minor. This is a very serious consequence, and we've seen discussions in the internet, on WhatsApp, in our groups, and even from some referring doctors who have decided to stop RAS blockers for incorrect reasons. Every single society has come down on this side. Do not stop RAS blockade, period. That's it. And all the societies have also come against this, unless there's an independent clinical ground. Traditional reasons, hyperkalemia, severe hypotension, and so on. There is no evidence of benefit of stopping, and in fact is going to expose to potential harm and more hospital admissions and more exposure to COVID-19. So how to avoid heart failure hospitalization? Using full guideline-directed medical therapy. And I'm just going to give you a slide from the Paradigm study. And this is old data now, it's 2014. If you look at the time after randomization, the curves diverge very quickly between enalapril and sacubitril valsartan. So if we have patients in this short period of time, the next 3 months when we expect COVID-19 to build up, we want to keep these patients out of the hospital, heart failure hospitalization reduced by almost 50% when you use sacubitril valsartan. And this is not a testimonial to sacubitril valsartan, this is to maximum guideline medical therapy, avoiding heart failure hospitalization. So, we'll go to the meat of the subject, remote consultation. I actually got this from the British Medical Journal. It's a very nice, simple way for all doctors to utilize some of the information in creating a telemedicine consultation, okay? We have a lot of stay-at-home guidelines. We're trying to be protective of the patient, but at the same time, not ignore things like serious comorbid conditions. So, First of all, set up your clinic. Either you're going to use WhatsApp video or bottom video or one of these phone apps. You also have to use it in patients who have multiple diseases or immunosuppression that you do not want them to be exposed to big crowds at the hospital. First of all, you have to test your connections, do all we do. I'm sure we can also use Zoom links with these patients now. And then we do a rapid assessment. The first thing to do is to listen to the patient and see what they're saying. Do they sound breathless? Are they talking fast, gasping when you're talking to them? This is the key point. And these are some red flags as you are assessing the patient. And these are actually based from the initial large cohort of patients from China, where we are actually looking at the red flag symptoms. So shortness of breath at rest, difficulty breathing, pressure or chest pain, cold, clammy or mottled skin, confusion. If the patient you're talking to appears to be confused or difficult to arouse, of course, if you see cyanosis, this is really important. These patients need fast track to the hospital. And then asking some specific questions that we don't normally ask in cardiology about neck stiffness and rash. When we are giving them, they suggest this checklist, which again is available on the BMG website, and I'm happy to share it as well. So focus on breathing. Focus on change in breathing. A rapid change in breathing is less likely to be heart failure than it is to be COVID-19. If possible, while you're watching on a high-resolution video, just like we're doing now, you can talk to the patient on a Zoom link, you can measure the respiratory rate, and the video can actually allow you to see how quickly the patient is breathing, in addition to how fast they're talking. So this is the important points in the red box here. So in addition to the history, cough and fever and fatigue and all of the other COVID suspicious symptoms, very important, breathing, lip color. Now, a lot of the patients will have a blood pressure machine at home. Almost all the patients really have it that can connect on the internet. Using a pulse oximeter, some of our patients have pulse oximeters, certainly the temperature, they can provide you this data while you're on the phone with them. And if there are features like tachypnea, tachycardia, confusion, or high fever, fast track them to the hospital. Now, this is another trick that we learned from the Heart Failure Association. Randall Starling is the past president of HFSA, and he's telling us, this is actually his Twitter account, how he's actually giving the patient instructions to look for lower limb edema. You see here, pitting edema, and this is actually looking at the neck veins. So any intelligent patient with a camera can just direct this to the right side of the neck, and you can just watch a moving video of the JVP, and it's very helpful actually for us to assess volume without having to bring the patient in. Some other important points: medicine reconciliation. The value of a video visit is you can actually see their medications. So you see this patient is on valsartan, they're on esomeprazole, they're on a statin, they're on dapagliflozin, metformin, and the patient's on furosemide. So it's a two-way conversation. The patient, we expected them to start on valsartan sacubitril and add spironolactone and reduce the dose of diuretic. By telling them on the picture, do this and do that, they don't get confused about the color of the pills or the number and so on. So this is direct communication with the patient. This is a real patient, which we actually ended up, instead of bringing her to the hospital, we switched her from valsartan to Arni over the phone. Other things, lower limb edema. I think this is pretty obvious. And we also end up sending to the patient a list of medications to confirm that they have understood what we did. This is a patient that we saw back in April 15th. It's a real patient, and we make sure that everybody understands the communication. So you can clearly modify the diuretics and optimize GDMT, which is what we did in this patient. And again, we can assess volume by looking at the neck and the lower limb edema. So some additional tools. We ask the patient to weigh themselves, and they show us the weight. Patients have a blood pressure monitor, so they can give us a picture. And of course, they all have glucometers when they have diabetes. So you can get a lot of information in a short period of time that tells you what's the next step for this patient. You saw this patient, blood pressure is excellent, so we have no problem titrating the valsartan sacubitril, adjusting her diuretics, and helping her stay out of the hospital during this time. One other important thing. A lot of our cardiac patients, arrhythmia patients, heart failure patients have devices, so ICD and pacemaker. If you have the facility for remote cardiac monitoring, this is phenomenal. because this will transmit to you. This is actually a strip from a patient who was sitting at home. We asked them to transmit an extra transmission, and this is what you see. Atrial flutter, this is the atrial electrogram, this is the ventricular electrogram with variable ventricular response. So this was very easy. We told the patient, look, you have new onset of atrial flutter, we need a prescription for a novel anticoagulant, okay? And this is likely to cause the patient to have worsening heart failure, so we ended up looking at the patient's Optival. So some of these machines, almost all of them now, are able to measure the intrathoracic impedance, and when the intrathoracic impedance goes down, there's more fluid, and you can see this patient, atrial fibrillation episodes on here, sudden increase of the fluid index. So not only were we able to anticipate the need for anticoagulation, we realized that the atrial fibrillation was triggering worsening of heart failure without the patient ever coming to the clinic. So this is really an important, tight way of monitoring the patient, but this is only for patients who have an implantable device. And the last group of questions and analysis is really how to identify, differentiate dyspnea due to COVID-19 or dyspnea due to heart failure. And this is a really important group of patients to try and assess, because the second group doesn't need to come to the hospital. They may adjust their diuretic dose. The first group needs to come to the hospital, get their CT scan, get their medications. So in order to reduce the healthcare resource exposure for patients who can be stabilized at home, it's important to have this clinical judgment pathway. So one of the important questions that we can ask is this virtual assessment guide. Travel history, nobody's traveling anymore. Social distancing or exposure to people with COVID-19. Positive contact, personal home care. On the other hand, long duration of symptoms of dyspnea, weight gain, edema. Edema, ascites, and weight gain, most likely heart failure, less likely COVID-19. De novo viral symptoms and fever, most likely COVID-19, and you can have something in between where pneumonia triggers the heart failure. So again, it can help you to try to make a decision about what to do. Now, some factors that increase the likelihood of COVID-19 is not being socially isolated, working in large groups, people who work in camps or compounds or factories. The fever is obviously an important symptom. Now, if you have a patient who does not have weight gain and does not respond to diuretics, most likely this is a COVID-19 patient. Lack of response to heart failure therapies. Now, one of the tricks that we've learned, unfortunately, is that natriuretic peptide can increase during COVID-19. So we were thinking to use this as a biomarker of patients getting worse with dyspnea and not having to come to the hospital, to send the lab to their house and see the BNP. So you have to use this with some clinical judgment. And again, follow-up communication. Very important to, very important to increase the frequency of visits, and you can do that quite easily by telephone or video encounters. Laboratory testing. You don't need to have the patients come to the lab to check a lipid profile. This is irrelevant. They need to take medication. You don't need to tell them to come to the hospital unless they have had deranged abnormal electrolytes or you are making significant changes in your medications. In this case, the solution is they can either come to the lab in your hospital, do the lab and leave, or you can have the lab technician or the nurse go to the patient's homes. Okay? So that should be, again, triage based on clinical need. Also, patients who are exhibiting over-diuresis, vomiting, diarrhea, changes in medications, frequent emergency room visits, these are the frail patients who need lab work. Other people, you can defer the routine lab tests for some time. And with that, I can thank you very much, and I think we can, at the chairman's discretion, take some questions and go to the next session.
Thank you, Professor Hany, for this very interesting lecture. We have here some questions. First question is, in COVID-19 with heart failure, reduced ejection fraction patients, which patient to give ACE, SGLT2 inhibitors, and ARNI? Thank you very much. This is the first question. Which patient to give ACE, SGLT2 inhibitors, and ARNI? How to choose which patients for each of these drugs?
So I think we will treat the HFrEF patient the same way as we would according to the guidelines, right? So if we have a patient who is already on an ACE inhibitor or an ARB, it's very important to switch them to the ARNI because we know that improves their survival and also decreases sudden death and heart failure hospitalization. If the patient is not on any of this category, we have to initiate this therapy. The thing to be careful about is that you have to look at the stage of COVID-19. We're now aware that there's basically 3 stages. There's the asymptomatic stage, there's the mild infection stage, and then there's the severe infection with the interleukin storm. Once they're in interleukin storm, this is a different patient. This is a patient in cardiogenic shock who's going to probably need dobutamine, milrinone, maybe even ECMO. They're all on ventilators, and maybe an IL-6 inhibitor or plasma, convalescent plasma. So I think the important thing is a lot of these patients present to medical community at an early stage. They have a low-grade fever, the CAT scan is showing mild infiltrates. Let's see if their ejection, if their biomarkers are abnormal, if their troponin is elevated, echocardiogram, limited echo is important. Don't do a full echo, look at your ejection fraction, do they have evidence of myocarditis? If they have myocarditis and they're hemodynamically stable and the LV function is impaired, you're going to treat them as if they're an acute patient. In that situation, you will start up titrating medications gradually while treating the infection. If they have no symptoms whatsoever and they have HFrEF, hit them with all the guideline medical therapy you normally would give them. You give them the beta blocker, you give them the ARNI is now the standard of care. If they're diabetic, they should be on SGLT2 inhibitors. They have to be on MRA. Give them the combination. But now you have the option of this telemedicine. You have the option of following them remotely, checking their vital signs at home, and doing sort of limited lab tests to see the response. So I think we'll just have to follow the guidelines. COVID-19 doesn't prevent us from following the guidelines. It just prevents us from seeing the patient face to face.
SGLT2 inhibitors, they are not yet in the guidelines. So which patients you will advise to prescribe this group of drugs for heart failure treatment?
Okay, so you're 100% right, they're not in the guidelines, but the DAPA-HF study has been a remarkable study and has shown us in non-diabetic patients a new mechanism that helps. So at the very least, every diabetic patient who has any evidence of heart failure or any diabetic patient who has any evidence of CKD should be on SGLT2 inhibitor. Now this is regardless of their A1C, regardless of the insulin use, regardless of metformin. This is to prevent worsening or progression of heart failure in the diabetic patient. I'm pretty sure, based on all of the seminars we've attended and the ACC, and I'm sure ESC is going to be coming up, that particularly SGLT2 inhibitors will be used to treat HFrEF patients. But right now, if you're not comfortable doing that based on the RCT data, definitely put the diabetic patient who has it on the SGLT2 inhibitor. And one other trick, reduce your diuretic dose by 50%. SGLT2 inhibitors are potent natriuretic drugs, and when the kidney function is nearly normal, you will really need to reduce your furosemide or bumetanide by 50% to avoid volume depletion.
Another question is regarding the lack of response to diuretics. This suggests or confirms COVID-19 infection. This is got from practice, or there is an evidence for this suggestion?
So the suggestion comes really from clinical recommendations. So this consensus paper that we talked about is from the Canadian Cardiovascular Society. It's a consensus. So the point is, if they don't respond to diuretics, again, you have to use your clinical judgment. Now, not respond to diuretics could be other things, cardiorenal syndrome, right? Diuretic resistance, salt intake. So
you had to put this in consideration.
In the context. At the same time, if you have your ability to see the patient's neck vein and the lower limb edema and the abdomen and the weight, it sort of goes more with the chronic condition. On the other hand, if you tell the patient, take a lot of diuretics and they're still short of breath, they appear very tachypneic. Remember, the problem with COVID-19 is a hypoxic problem. It's not a vascular problem, right? There's a perfusion-diffusion abnormality. So if that's the problem and the patient is predominantly dyspneic, come to the emergency room. I mean, we have to make a very smart decision. Go to the hospital or not go to the hospital. Now, the consequences could be really bad. So using these extra tools and technology, I think we can make the right decision.
Another question, the use of SGLT2 inhibitors in non-diabetic patients. do we have a risk for hypoglycemia in these patients? This is the question.
Excellent question. The answer is absolutely not. So the really tremendous data we got from the DAPA-HF, and I'm sure we're going to get that from the EMPEROR studies and so on, the SGLT2 inhibitor only gets rid of the excess glucose, excess glucoresis. Once the glucose levels are equal in the tubule, the system shuts off. So it has a built-in safety mechanism that never causes hypoglycemia. Hypoglycemia can occur in diabetic patients if they are on SGLT2 inhibitors on top of insulin, on top of sulfonylurea. So it's usually the sulfonylurea and the insulin that's responsible for hypoglycemia, not SGLT2 inhibitors, which has led to the approval in non-diabetic patients.
Another
Hany,
question.
I have two questions. تفضل حسين تفضل.
Last question from the audience. In patients with HFpEF, are there any drugs with proven benefit regarding decreasing morbidity and mortality?
Okay, very good question. So we have 2B level of indication for aldosterone antagonist. As we know from the TOPCAT study, there was reduction in heart failure hospitalization. From the CHARM, candesartan preserved arm, again, there was reduction in heart failure hospitalization, nothing on all-cause mortality. The recent Paragon study with valsartan sacubitril did not meet clinical significance by 7 cases, but when they reanalyzed the patients to include patients with preserved ejection fraction up to 57%, these patients benefited from reduced heart failure hospitalization. So I think we're chasing something that's not going to happen. Mortality in heart failure with preserved ejection fraction is generally lower than HFrEF. So I don't think we're going to be able to reach something like a statin, for example, or ACE inhibitor that lowers mortality. But if we reduce hospitalization, this is an important concept for the patient and for the healthcare system to reduce recurrent admissions. So we may not get it. Now we're going to wait for the SGLT2 inhibitor data because, as you know, there's the preserved ejection fraction arm of EMPEROR and dapagliflozin. If we see that in diabetic patients there is prevention of heart failure, there may be a value there too.
Okay, Dr. Hany, thank you very much. It's an excellent presentation, excellent lecture as usual. I'm becoming a fan of your lectures, as you know. Allah يخليك يا بيه. My question is about, is there a role of prophylactic use of ACE inhibitors, maybe with guided by BNP or guided by troponin, before we get heart failure in these patients? Or you don't think that we have enough data until now? In the context of COVID-19 patients.
Right. So what we have been doing is sort of a hybrid of this, and this is not totally evidence-based. Remember, we are all learning about this horrendous disease, and our infectious disease doctors are also struggling as well with the correct treatment. So when we see the patients, we try to risk stratify them from day one. So our protocol may be a little bit complicated, but we get a D-dimer, we get a BNP, we get a troponin, and in the patients getting the ICU, we do an IL-6 level, okay? And ferritin as well. If they seem to have a lot of biomarker elevation, an echo is always done, but of course to protect our junior staff and technicians, we do a limited echo with full PPE. The limited echo has only 2 objectives. What is the LV function? So myocardial dysfunction, wall motion abnormality, and pulmonary artery pressure. If they appear to have those 2 abnormalities and they are hemodynamically stable, we will treat them as a nascent myocarditis. And in this case, before the EF drops, we generally would start the patient on a beta blocker, right? And this is based on the idea that they are going to be developing tremendous cytokine storm and adrenergic activation because of the infection. Now, this may not be totally evidence-based, but we have seen that sometimes it blunts the cardiovascular element of the response. And when this is a critical time. This is before they go into renal failure. This is before they go into the fulminant lung toxicity. And sometimes we're able to catch them that way. So we treat them as if they are heart failure with moderately reduced ejection fraction. So a HFrEF patient. If the kidney function allows, we will start small doses of ARB. We try to avoid ACE inhibitors because of the cough, right? Because these patients have a tremendous cough, so we try to go with ARB in the beginning. Now, this is essentially the idea that they are being treated as a moderately reduced ejection fraction that is sort of in progression. All right? One other thing we do, if the D-dimer is 2.5 times the upper limit of normal, we will perform focused ultrasound of the arm and leg, and if that is even slightly abnormal, we put them on full dose heparin, right? Because these are the thrombotic complication that's recently been reported, and one of our colleagues actually published something like a sort of a pathway when to use full dose heparin in these patients, and it's surprisingly effective, surprisingly effective.
Dr. Hany, this is Nabil Farag. May I ask you a question?
It's my pleasure.
Thank you very much for your great presentation. I enjoyed it very much. And I would ask you about the use of telemedicine in the COVID-19 era.
Yes.
You know that here in Egypt, we don't have, we didn't develop such telemedicine. We don't have hospitals that capable of doing such sophisticated telemedicine. You have it in your beautiful hospital in Abu Dhabi, but we don't have it in Egypt. We have some sort of telemedicine like social media, WhatsApp, some things like this.
Right.
We got telephone calls from our patients, but I don't think this is enough to have a proper consultations from our doctors. What's your advice as regard Egypt?
So I can tell you that telemedicine, I'm not happy with it. I mean, believe me, this goes against everything I've done or been trained to do in the last 25 years. I mean, I like to touch and feel the patients. You know, I am still very much a clinician. I use the stethoscope a lot. So the problem is that also patients are afraid to go to the hospital. There's this impression that in the hospital there's a lot of COVID-19. I want to stay away, right? In fact, last week we were fortunate enough to open a limited number of patients in the EP lab. Out of 10 patients that have been waiting 3 months, only 2 agreed to come. Very scared, and I don't blame them, right? So it's better than nothing, but it's not optimal. So what have we done? So actually our hospital didn't actually have a telemedicine unit or setup, so we came up with this weird hybrid. So some of these pictures I showed you are actually from my WhatsApp account, right? So what I do is I call the patient on the phone, I give them instructions, do this, this, and this, take pictures. Now some of them have younger family members that can do the video or something like that. Almost everybody can measure their blood pressure, right? And at least we have the basic vital sign data. What I found is that the social media, and you know, a lot of people now have 4G phones, and you know, even in the absence of a healthcare network, they can still transmit you relevant data. So the basic things that the patients can help us with: vital signs, weight, lower limb edema, medication reconciliation. Now, when things become a little bit uncertain and any concern about breathing is raised, my first trick is, okay, we're going to double your diuretics. I'm going to call you tomorrow morning and tell me what's happening. Okay? Not getting better? Fine. Then we've done our valiant effort and they have to come to the hospital. The important thing that the patients have to learn is that there is, for us even, not a very critical way that we can tell them you are completely safe or not, right? That's the only thing we can do. And we have some of our nurses are on the phone with so we have a heart failure clinic, and we have a heart failure nurse and coordinator. So because they're not doing anything in the clinic now, we're giving them phone call tasks. Call these 100 patients today, the next patients tomorrow, and so on. Make sure they are okay, at least self-described. That's the basic minimum, so we keep track of the patient. So what this has told us is that we are very thankful that we created a list of patients with heart failure in our clinic. By having this list, we know how to get back to them. We're not waiting for them to come into the hospital, we are prospectively calling them. So in fact, it was the list of patients rather than the technology that was helpful, because we're able to know who's coming and who's not. I'm sorry it's a vague answer, but you know, everybody's just sort of learning how to insert this disease into an outpatient practice. And in terms of what Dr. Sameh mentioned, which was very nicely written in your paper, limiting outpatient testing. So for the last 3 months, we haven't done a single exercise stress test. If the patient needs coronary evaluation, CT angio, cardiac cath, finished. We need to get it done quickly with a complete answer. No role for recurrent visits. Again, the echoes, we are being very deliberate who gets an echo. If it's a routine echo patient with long-standing AS for a long time, wait. Follow-up of mitral valve disease, wait, right? So very focused, very high-value echoes. Holter monitors, only in patients who are having syncope that we don't want to admit to the hospital. Nobody else, right? So we created sort of a large checklist of things that are valuable or can be deferred. Tamam? Transesophageal echo. We basically stopped transesophageal echo because of the intense amount of aerosolization that happens. It exposes our colleagues and the patients and the anesthesiologist to too much. So we were basically telling patients, anticoagulate for a month, come back and cardiovert or rate control.
Okay, we have a question. Is it safe to continue on beta blockers in patients with hypoxic COVID-19 with chronic heart failure?
Right. So again, this is important. We do not withdraw RAS blockers or beta blockers. Hypoxia in these patients is due to a vascular problem. It's usually pulmonary thrombosis and inflammation. Remember, the contraindication for non-selective beta blockers was reactive airway disease, in other words, bronchial asthma. And these patients don't have any of this, right? If you allow them to become tachycardic, they eventually will become tachycardic, hypotensive, and they're going to spin out because of heart failure. The last thing you want is to have a patient with COVID-19 decompensate with the heart failure. There is really no data on absolutely no data on withdrawing guideline medical therapy, unless the patient becomes hypotensive or develops an acute, CKD. So basically a traditional contraindication. The moderate COVID-19 patients who are managed on we have a ward. We had a very large ward where patients who are sort of semi-sick, moderate patients, continue all guideline medical therapy until they are able to wean off oxygen.
Dr. Hany, the COVID-19 has changed our practice, our lifestyle first, and then, of course, our medical practice. So do you think that more invasive monitoring of heart failure patients will have a future, something like pulmonary artery pressure monitoring or something like this? Do you think that now we will be more dependent on such indicators, or it's still premature to say this?
So I can tell you from our point of view, one of the things that we have actually deferred in the last 3 months is right heart caths and cardiac biopsies for even our transplant patients, except the ones that we were suspecting or grade 2. So the right heart cath, as all of you know, is central in pulmonary hypertension and in the transplant patient and so on. We have actually pulled back from that and used biomarkers and echo as much as we can. On the other hand, in the ICU, in these patients who are looking like they're going into cardiogenic shock or cardiorenal syndrome, we have several patients we actually put on ECMO, and thankfully they took a long time but have recovered. So as we go to advanced therapies, invasive monitoring is going to be more utilized. And I think the problem there is a lot of the hospitals are not set up for invasive monitoring. I mean, it's been a lost art in some ways in many of our facilities here. And it's going to be very important when you have a cardiorenal patient who also has COVID-19. What is this? Cardiogenic shock, septic shock, both. So knowing the cardiac index is very important, knowing how to titrate medication, giving nitric oxide. There's been a lot of use of nitric oxide. I'll be perfectly honest with you. Our intensivists have done a really phenomenal job of doing prone position ventilation, nitric oxide, advanced ventilatory techniques. I think that's what's saving these patients, honestly. I think this is what's helping them. Maintaining oxygenation for as long as possible, and then the perfusion takes care of itself.
Okay, thank you very much. Wonderful discussion.
Thank you. Now I think we have to go to the second lecture. Professor Nabil Farag will talk about the use of Eplerenone in the treatment.
Thank you, Hassan, for the introduction. It's my pleasure to be here with my dear friend Dr. Sameh, Shaheen, and Dr. Hossam. I would like to thank Biofactor and Biofactor team giving me the opportunity to give this presentation. My main presentation will be about the mineralocorticoid receptor antagonist, mainly Eplerenone, in the management of heart failure patients. But first of all, I would like to give just more introduction about the COVID-19 and cardiac patients. This is a very important slide. This As we all know that throughout the history, humans spread across the world, and infectious disease have been a constant companion. مفيش مكان بنروح إلا لما يكون معانا infectious disease. Even in the modern era, infectious disease and outbreaks occur constantly. Looking at this slide visualizes the history of the most deadly pandemic events, starting very early in life, 165 to 180 سنة 1165 و 180, when we have this Antonine plague that killed 5 million people, passing by the most deadly pandemic in 1347 till 1351, when we have this bubonic plague that killed 200 million people. And now we have the COVID-19. The COVID-19 till 7th of April killed about 78,000 patients. But recently, just one day ago, this COVID-19 killed more than 400,000 patients. So the figure goes up from 78 in the 7th of April to 412,000 deaths in the 10th of June. And as we all know that the WHO declared the COVID-19 as a pandemic disease in the 11th of March this year. A very common question, because we know that COVID-19 is due to coronavirus too. Very common question, what is coronavirus? As we see here, that coronavirus is a large family of viruses that cause illnesses, from the common cold to more severe diseases like MERS and SARS. MERS is a Middle East respiratory syndrome that first identified in Saudi Arabia in 2012 and killed over 800 people, and the way of transmission was from camel to human. And a second pandemic, that severe acute respiratory syndrome, SARS, that identified in 2003 and killed over 650 persons in China. And the way of transmission was from the pets to cats to human. And recently we have the new strain of the coronavirus, which is a coronavirus 2, that is discovered in China. And the first with coronavirus 2 was in December 2019. And the way of transmission was from human to human. This is a coronavirus element. And a very common question is, what is the mortality rate due to this COVID-19 patients? And this is a case fatality rate that was reported to be 15% in the initial period. This was a very big figure, but this estimate was calculated from a small cohort of hospitalized patients. Subsequently, with more data emerging, the case fatality rate decreased to between 4.3% and 11%, and lately, even to lower, up to 3.4%. And this is a very important slide, show how to test our healthcare system. This is the main parameters or the main standards that we can measure the efficiency of our healthcare system. For example, prevention, detection and reporting, rapid response, robust health system, compliance with global norms, and risk environment assessment. These are the main parameters and main measures that we can assess the efficiency of the healthcare system all over the world. Unfortunately, COVID-19, by this disease, we discovered that we have a very weak healthcare system all over the world. That by these parameters and by these standards, they found that while there were top performers, definitely we have some very good healthcare system and healthcare security. The healthcare system around the world on average are fundamentally weak and not prepared for new disease outbreaks like COVID-19 we are facing nowadays. This means that we have to develop our healthcare system all over the world, not only in our country, but also all over the world. And here come our responsibility. And this, our responsibility is to keep us safe. To keep us safe, first, to have social distancing, and we have to keep a distance between you and the others when you go outside your home, and to wear surgical mask and to wash your hands regularly with soap and water. And this is an example that when we reduce the social exposure by 70%, that if we have one person infected at day 1, this person will infect only 0.625 people at day 5, and this will lead to 2.5 people will be infected at day 30. And if we reduce this social exposure by 50%, if we have one person infected at day 1, we'll have 1.25 people infected at day 5, and 15 people will be infected at day 30. So we with less social exposure, we'll have less infection, and with more social exposure, we'll have more and more infection. And so if we don't have this social distancing, so if we have one person infected at day 1, we'll have more than 400 people will be infected at day 30, and this the importance of social distancing and to keep us at home as much as we can. And this is the virtue of the COVID-19. We have actually 3 stages: stage 1, stage 2, and stage 3. Stage 1 is the early infection, which is a viral response, and this is usually presented with a mild symptoms in the form of low-grade fever, dry cough, diarrhea, and headache. And stage 2, where the lung starts to be affected. And in this condition, the patient starts to complain of shortness of breath and hypoxia. And with this stage, definitely, lung imaging like CT will be abnormal. And the third stage is a hyperinflammatory phase, or what we call the cytokine storm. And this cytokine storm will lead to ARDS, respiratory failure, and these patients will need a mechanical ventilation, will lead to shock and heart failure. And this stage will be associated with elevated inflammatory markers like CRP, interleukin-6, G dimer, ferritin, troponin, N-terminal propane B, and PNB. All of these markers will be elevated in the third stage with cytokine storms. And accordingly, the host response can be either no symptoms, and this occur in about 30% of the contacts. And this is associated with 0% death rate, or mild moderate symptoms. This occur in 50% of the patients. And again, this is associated with 0% mortality rate, and only 10% will have severe symptoms, and about 15% of these 10% will die of the disease. And those who will have a critical symptoms, like those who will develop ARDS and will need a mechanical ventilation, and this represents only 5%, and the mortality rate in this group of patients will be 50%. So half of these critically ill patients due to COVID-19 will die from this disease. A very important question we ask us every day is cardiovascular disease patient at high risk for COVID-19? The answer comes from a meta-analysis of 6 studies, including 1,527 patients with COVID-19, examined the prevalence of cardiovascular disease and reported the prevalence of hypertension to be 17.1, cardiac and cerebrovascular disease to be 16.4, and diabetes to be 9.7%. And patients with underlying cardiovascular disease appear to have an increased risk for adverse outcomes with coronavirus disease. These patients are not at increased risk to catch the disease, but when they catch the disease, they are at increased risk for poor outcome as regards morbidity and mortality. And although the clinical manifestation of COVID-19 are dominated by respiratory symptoms, some patients also may have severe cardiovascular damage. I will explain this later on, and I explain the pathophysiology for this cardiovascular damage later. So it is important for patients with heart disease to follow the Center for Disease Control and Prevention recommendation to prevent infection. For example, patients who are at high risk should practice social distancing, should stay at home, and should wear surgical masks, go out, and should wash their hands every frequently. And this is the mortality risk and the mortality rate. It's a very common question because the overall mortality rate is only 2.3. But this mortality rate jumps to 6% in hypertensive patients, 7.3% in diabetic patients, 10.5% in cardiovascular disease patients, and 14.8% for elderly patients above the age of 80 years. A very important notice is that the case mortality rate for underlying cardiovascular disease is double that of patients with underlying chronic respiratory disease. So the mortality rate with cardiovascular disease is much higher than those with chronic respiratory disease from COVID-19. And this is the exact pathophysiologic mechanisms underlying myocardial injury. This is actually not fully understood, and this is hypothesis. Cardiac involvement and cardiac injury due to COVID-19 could be due to the direct damage by the virus, viral damage of the myocardium, or due to the release of systemic inflammatory response, excess cytokines release like interleukin-1 and interleukin-6 leading to myocarditis and heart failure. And this cytokine release also can cause destabilization of coronary plaques in the coronary arteries leading to acute coronary syndrome. That's why some patients with COVID-19 may present with ST elevation MI or non-ST elevation MI due to the COVID-19 itself and not due to the atherosclerotic coronary artery disease. And the fourth mechanism underlying the cardiovascular affection due to COVID-19 is the aggravated hypoxia due to lung injury. This aggravated hypoxia will lead to supply-demand mismatch that decreased oxygen supply to the myocardium will lead to some sort of ischemia. Therefore, patients with cardiovascular disease are more likely to experience myocardial injury after COVID-19 infection and at higher risk of death. And this is how the virus go inside the cells. Usually, the coronavirus 2 uses the angiotensin converting E2 receptors, which are mostly found in the respiratory tract, but they also found in the heart and the kidneys. And the virus infects the target cells, causing damage. The resulting inflammatory and immune response can cause pneumonia to develop in most severe cases, or can cause even myocarditis in the heart. And this figure highlights the key manifestations and the hypothetical mechanisms underlying the cardiovascular involvement in COVID-19. We can see that the virus enters the cells through the angiotensin converting enzyme inhibitor 2, mainly in the lungs, and sometimes through in the heart and kidneys. And through these cells, they stimulate the T macrophages to release excess cytokines, what we call the cytokine storm. Cytokines will lead to myocarditis, and this myocarditis will end up by myocardial damage, arrhythmias, and heart failure. And also these cytokines may cause plaque instability and plaque rupture, leading to acute coronary syndrome. So this is the hypothetical mechanisms underlying cardiovascular involvement in COVID-19 patients. Going to my main presentation, it's a heart failure and role of Eplerenone in patients with heart failure. And as we know, all of us know, the European Society of Cardiology Guidelines 2016 as regard treatment of patients with acute and chronic heart failure. And this is the classification of heart failure and types of heart failure based on the European Society of Cardiology Guidelines 2016. And they classified heart failures into 3 types. The first is a heart failure with reduced ejection fraction, what we used to call this a systolic heart failure. And this heart failure with reduced ejection fraction should have symptoms of heart failure, plus or minus signs of heart failure. But the most important is that the ejection fraction should be 40% or less by echocardiography. And those with heart failure with preserved ejection fraction, and also this patient should have symptoms of heart failure, plus or minus signs of heart failure. And again, their ejection fraction by echocardiography should be 50% or more, plus elevated level of natriuretic peptides, and at least one additional criterion. For example, relevant structural heart disease like left ventricular hypertrophy or left atrial enlargement, and diastolic dysfunction as assessed by mitral flow. And the third type of heart failure is heart failure with mid-range ejection fraction. And again, this is exactly like heart failure with preserved ejection fraction. But the only difference is that the ejection fraction is between 40 and 49. And this patient should be dealt with exactly like patients with heart failure with preserved ejection fraction. And this is a definition of heart failure as defined by the American College of Cardiology, American Heart Association. It is similar to that of the European Society of Cardiology, but there is one major difference. The classification is number one, heart failure with reduced ejection fraction, exactly like that of European Society of Cardiology, ejection fraction of 40% or less. And this is referred as systolic heart failure. Or heart failure with preserved ejection fraction, again, this patient have an ejection fraction of 50% or more, plus symptoms of heart failure, and this is what we used to call a diastolic heart failure. And borderline, which is equivalent to the heart failure mid-range ejection fraction defined by the European Society of Cardiology, an ejection fraction between 41 to 49. And this is the main difference is that a heart failure with preserved ejection fraction improved. That's to say that this group of patients were having a heart failure with reduced ejection fraction that received the guideline directed medical therapy, and the ejection fraction improved and exceeded 40%. When the ejection fraction exceeded 40%, we call this group a heart failure with preserved ejection fraction improved from that with reduced ejection fraction. And this is the stages and phenotypes of heart failure. We have either at risk for heart failure or those with heart failure. At risk with heart failure, we have either stage 1, and stage 1, these patients who are at risk for heart failure, for example, hypertensive patients, patients with atherosclerotic coronary heart disease, diabetic patients, or patients with metabolic syndrome, but they don't have any structural heart disease or symptoms of heart failure. And stage B, these patients who have a structural heart disease, but without signs or symptoms of heart failure. And the other group, which is a heart failure, which is stage C. Stage C, they have a structural heart disease with prior or current symptoms of heart failure. And again, this group were further classified into heart failure with preserved ejection fraction, as we explained before, and heart failure with reduced ejection fraction. And the fourth stage, which is stage D, is a patient with refractory heart failure. And this is how to confirm the diagnosis presenting with chronic heart failure. These are how to suspect these patients. Number one, we have to assess the heart failure probability by the clinical history. For example, history of coronary heart disease, hypertension, use of diuretics, exposure to cardiotoxic drugs, those who are receiving some types of chemotherapy, radiation, and presenting symptoms like orthopnea and paroxysmal nocturnal dyspnea. And on physical examination, you may find an increased GVP or displaced cardiac apex, or you may hear a heart murmur, or you may find bilateral lower limb edema, or you may find any abnormality in the ECG. So if all of these parameters are absent in this condition, heart failure is highly unlikely. But if we have one or more of these parameters, in this condition, we have to assess the natriuretic peptides, either PNP or N-terminal pro-PNP. If the PNP or N-terminal pro-PNP is normal, in this condition, heart failure again is highly unlikely. But if either one of them is high, in this condition, you have to do an echocardiography to confirm the diagnosis. But if you have a normal echocardiography after this, again, in this condition, heart failure is highly unlikely. But if we don't able to do natriuretic peptide, you can jump directly to an echocardiography if you have one or more of these parameters found. You can ask for echocardiography to confirm the diagnosis of heart failure, and once heart failure diagnosis is confirmed, you have to determine and search for etiology and start appropriate treatment. going to the aldosterone and aldosterone antagonists, and this is the role of aldosterone in the renin-angiotensin-aldosterone system. As we all know that the renin is released from the juxtaglomerular apparatus from the kidney, and this renin convert angiotensinogen into angiotensin 1. And angiotensin 1 is converted into angiotensin 2 by the angiotensin converting enzyme. This angiotensin 2 has a lot of injurious effects all over the organs, on the heart, on the kidneys, and on the lungs. And this angiotensin 2 will lead to excess production of aldosterone. Excess production of aldosterone will lead to sodium and water retention, aggravating the volume overload in heart failure patients and aggravating their symptoms. In addition, this aldosterone has a toxic effect or injurious effect, direct effect on the heart. That's why mineralocorticoid receptor antagonist has a very important role in patients with heart failure with reduced ejection fraction. That's why the European Society of Cardiology guidelines recommend mineralocorticoid receptor antagonist for patients with heart failure with reduced ejection fraction who remain symptomatic despite treatment with ACE inhibitors and beta blockers to reduce the risk of heart failure, hospitalization, and death. I would like to highlight that this is a class 1 recommendation. It's the highest recommendation, level of evidence A. And again, I would like to emphasize that this mineralocorticoid receptor antagonist will reduce the risk of heart failure hospitalization and will reduce the death from heart failure. That's why it is recommended, it's highly recommended by the European Society of Cardiology to use it in patients with symptomatic heart failure and in spite of using ACE inhibitors and ARBs. And this is a therapeutic algorithm for patients with heart failure with reduced ejection fraction. Number 1, and this is class 1 recommendation, is to start with either ACE or ARBs. If the patient is intolerant to ACE, you can replace this with ARBs and beta blocker. And then you have to up-titrate both ACE and ARBs to the maximum tolerated evidence-based doses. And if the patient is still symptomatic, again, this is a class 1 recommendation, level of evidence A, to add mineralocorticoid receptor antagonists. Again, because these drugs can reduce the number of hospital admissions due to heart failure and also can reduce the mortality due to heart failure. That's why it's class 1 recommendation, level of evidence A. And this is how to use an important drugs like mineralocorticoid receptor antagonists. For example, Eplerenone. Eplerenone is used as an initial dose in 25 milligram once daily, and this dose should be up titrated to 50 milligram, but this based on the level of potassium. So you have to check the potassium level before up titrating the dose of mineralocorticoid receptor antagonist, and I will mention this later on in other slides. And this is American College of Cardiology, American Heart Association, and Heart Failure Society of America focused update. And again, they mentioned very clearly that the clinical strategy of inhibition of the renin-angiotensin system with ACE inhibitors or ARBs or ARNI in conjunction with evidence-based beta blockers and aldosterone antagonists in selected patient is recommended for patients with chronic heart failure with reduced ejection fraction, again, to reduce morbidity, hospitalization from heart failure, and mortality, cardiovascular death due to heart failure. So both European Society of Cardiology and American College of Cardiology agreed for the same concept with the same level of recommendation, the class 1 recommendation to use this mineralocorticoid receptor antagonist in patients with heart failure and reduced ejection fraction. And again, this is the European Society of Cardiology guideline recommendation for the management of acute coronary syndrome in patients presenting without persistent ST segment elevation for those with unstable angina or non-ST elevation MI. And again, they mentioned very clearly that mineralocorticoid receptor antagonists, preferably Eplerenone, because we have the evidence behind this, are recommended in patients with LV ejection fraction of 35% or less, and either heart failure or diabetes after non-ST acute coronary syndrome, but no significant renal dysfunction or hyperkalemia. And as I mentioned before, potassium monitoring of potassium is very important in patients who are receiving mineralocorticoid receptor antagonists. And again, this is class 1 recommendation, which is the highest class, level of evidence A. To know the main difference between spironolactone and eplerenone, and to know why eplerenone has less side effects than spironolactone, you have to know the structural characteristics of each one of them. For example, spironolactone, who developed in 1950, is an anti-mineralocorticoid with structural elements of the progesterone molecule. Thus, it's associated with abrostogenic and anti-androgenic adverse effects. That's why the incidence of gynecomastia is high with this drug. While eplerenone is a spironolactone derivative designed to enhance selective binding to the mineralocorticoid while minimizing binding to progesterone and androgen receptors. That's why eplerenone is not associated with gynecomastia as a side effects. And so the profile of the drug of eplerenone minimized or even abolished this important side effect that happened due to the use of spironolactone. Going to the evidence behind the use of eplerenone, we have 3 trials. I will go rapidly through this. We have the emphasis, we have the emphasis heart failure, and we have the reminder heart failure. I will start with the emphasis heart failure that was published in 2003, use of this drug in post-myocardial infarction patient, and these are the patient characteristics. There was no difference between the group who received eplerenone and the placebo, and I would like to highlight that patient in both group were having an ejection fraction of 40% or less. So these are the patients with heart failure with reduced ejection fraction. And this study included 3,300 patients that were randomized to eplerenone 25 milligram and 3,300 patients to placebo. And the main follow-up of this patient were 16 months. And the results of this trial, there were a 15% relative risk reduction in all-cause deaths and 13% relative risk reduction in cardiovascular deaths or hospitalization, 21% relative risk reduction in sudden cardiac death. And if we look at the curves here, we can see that very early separation of the curves from the first months in favor of the use of eplerenone as compared to placebo. That's why eplerenone reduced mortality in the first 30 days after randomization in patient post myocardial infarction, while in the RALS trial, spironolactone was able to reduce mortality after 2 to 3 months of use of such drug. Going to the emphasis heart failure trial, use of eplerenone in patients with systolic heart failure and mild symptoms. Again, these patients were having heart failure with reduced ejection fraction, but they have New York Heart Association class 1 or 2, these mild symptoms. And this study included 737 patients in the New York Association class 2 heart failure, mild symptoms, and an ejection fraction of no more 35%. And this trial was stopped prematurely according to pre-specified rules after a median follow-up period of 21 months. And the primary outcome occurred in 18% of patients who were receiving eplerenone and 25.9% in the patients who were not receiving this drug, and the difference between both groups were highly significant. And we can see here, that cardiovascular mortality or heart failure hospitalization was reduced by 37% in the patient who received eplerenone. Those patients, again, with heart failure with reduced ejection fraction and mild symptoms. And again, hospitalization for heart failure was reduced by 42%. And this is a very important point, is to minimize the morbidity in a patient with heart failure, is to decrease the number of hospital admission in patients with heart failure, because these patients usually require 1 or 2 admission every year because of the deterioration of their symptoms and duration of the heart failure. And the last trial I would like to mention is a reminder that the use of Eplerenone very early in post-acute ST elevation myocardial infarction without evidence of heart failure. And these patients with ST elevation myocardial infarction, the number of patients were over 1,000 patients without a history of heart failure. And they found that patients who received Eplerenone as compared to placebo, there was a 42% relative risk reduction in the primary endpoint of cardiovascular mortality, rehospitalization, and the length of hospital stay due to the disease. As regards the side effects, when we compare Eplerenone with mineralocorticoid receptor antagonist spironolactone, we mentioned before the structural characteristics of both drugs. And as we see here that in the RALS trial, 10% of the patients who were receiving spironolactone developed gynecomastia. And this one of the causes of to stop the drug in such patients. But in the Ephesus trial, Eplerenone was not associated with this important side effects. This gynecomastia was as equal as those in placebo group. Again, this is due to the characteristic structure of the Eplerenone and the structural characteristics of spironolactone, as I mentioned before. How to use this drug in a patient with renal and hepatic impairment? In patient with mild renal impairment, that is to say, GFR between 60 and 90, we don't need dose adjustment in such patients. In patient with moderate renal dysfunction, in this condition, Eplerenone can be used, but you can use it by 25 milligram every other day. But in severe renal dysfunction, Eplerenone is contraindicated. For patients with mild to moderate hepatic impairment, we don't need any dose adjustment, but in those with severe hepatic impairment, again, Eplerenone is contraindicated to use. And this is how to up-titrate the dose of Eplerenone based on the potassium level. First of all, before using mineralocorticoid receptor antagonist, you have to check both the renal function and the potassium level. And then you start by 25 milligram Eplerenone, and then you check the potassium level after 6 days. If the potassium level is still less than 5, in this case, you can increase the dose of Eplerenone from 25 milligram to 50 milligram once daily. But if the potassium level is between 5 and 5.4, in this case, you keep the same dose, the initial dose, which is 25 milligram. But if the potassium level is between 5.5 and 5.9, either you halve the dose or to stop the drug. But if the potassium level is 6 or more, in this condition, you have to stop the drug immediately. And as we all know, we have now this Eplerenone in the 2 doses, 25 and 50 milligram. What we need to know about the mineralocorticoid receptor antagonist is that we have the evidence, we have the large clinical trials. We have the RALS trial for spironolactone, we have the Ephesus trial for the Eplerenone. Both have shown that aldosterone receptor antagonists to be an effective treatment for patients with advanced symptomatic heart failure or post-myocardial infarction or post-infarction heart failure patients. And I would like to highlight that it is mentioned very clearly is Eplerenone is licensed for post-myocardial infarction use, both with and without heart failure. And the second point is that spironolactone and Eplerenone have similar inhibitory effect on the mineralocorticoid receptor activation. That's why we use the same doses, 25, 25, 50, 50. We use both doses. But the adverse effects, and this is very important to remember, the adverse effect profile are different. Eplerenone selectively yields a superior tolerability profile in terms of sexual side effects and gynecomastia because it doesn't have the anti-androgenic effect like spironolactone. And the last point I would like to mention is more data become available, the indication for use of aldosterone receptor antagonist could expand to include patients with mild heart failure symptoms like those patients in the reminder study, and heart failure with preserved ejection fraction. And I'll come to my end of my presentation. I would like to thank you very much.
Thank you, Professor Nabil, for this very informative lecture. Yeah, actually, I'm encouraging the audience to write their questions for Professor Nabil. Anyone have a question? دكتور نبيل، يعني أنا ليا سؤال برضو فيما يخص استخدام الإبلينون في عيانين الهارت فيلير. Do you recommend starting Eplerenone from the first day of diagnosis of heart failure, or you added in a stepwise approach after other drugs that are proved in heart failure to be beneficial in reducing mortality?
Thank you, Hassan, for these important questions. I'm sticking to the guidelines, and I'd like to go through the guidelines and use it in my practice. And as I said that European Society of Cardiology guidelines mentioned you have to start with ACE inhibitors or ARBs in patient intolerant to ACE plus beta blockers, and to up-titrate the dose of both the ACE and ARBs to the maximum dose recommended by the guidelines. And if the patient is still symptomatic in spite of using such drugs in such condition, we can use Eplerenone as add-on therapy for both ACE inhibitors and beta blockers.
Dr. Nabil, is there any difference in using ARNI with Eplerenone? I mean, more precautions or more strict follow-up of the potassium and the renal functions? What do you think about the combination of ARNI rather than ACE inhibitors with Eplerenone?
شكرا دكتور سامح. طبعا this is a very important question, but I think the same precautions. Definitely, ACE inhibitor and ARBs can cause elevation of potassium, as well as the mineralocorticoid receptor antagonist. ARNI also can cause elevation of potassium in addition to mineralocorticoid receptor antagonist. And we can use the same precautions that we have to monitor the renal function and potassium before using this mineralocorticoid receptor antagonists in both those who are using ACE inhibitors and ARNI, and to monitor this regularly after 6 days and after 4 weeks, and then every 3 months later on, just to be sure that there is no evidence of hyperkalemia needed to reduce the dose of mineralocorticoid or to stop the dose of mineralocorticoid receptor antagonists.
We have a question beyond the scope of this lecture. Let me read it to you. What about cases of non-ST segment elevation and high rising troponin in non-febrile patient with atypical or typical chest or hypertension? And another question, where is the other question? I think the other question was about using a patient with D-dimer, elevated D-dimer with non-ST elevation, already with non-ST elevation on antiplatelets. Is it safe to give anticoagulants in this patient? This is the question that I remember to read before.
For patient presenting with acute coronary syndrome, we use a triple therapy. We use a dual antiplatelet therapy. We use the aspirin and the P2Y12 inhibitors in addition to the anticoagulants. We use this routinely, specifically low molecular weight anticoagulants. And we have the European Society of Cardiology guidance recently. This is not a guidelines, it's a guidance. That patients presenting with non-ST elevation or patients presenting with acute coronary syndrome, all of these patients should be tested for a COVID-19 possibility. Patient with ST elevation MI, based on this guidance, should be treated by primary PCI even before testing for COVID-19, and should be isolated, treated with primary PCI, put a special room and do the test for COVID-19. And if the test is negative, can be dealt with as a normal patient. And if it's positive, so you can treat it as a COVID-19 patient. In a patient with non-ST elevation MI, those who came with stabilized on medical treatment, we can postpone the intervention 24 hours, for example, and we can do the test, the PCR test, and if they are negative, we treat this patient in the usual way, and if it is positive, we isolate this patient, and also we can do intervention for such patients. And again, triple therapy for all of these patients with acute coronary syndrome, the dual antiplatelet therapy, which is the aspirin, the B2Y12 inhibitors, and the heparin, enoxaparin are indicated in such patients. So we use it routinely in every patient with acute coronary syndrome.
That's a very nice question. I think any patient who comes into the hospital, we have to regard as COVID-19 in this time.
Yes,
not
yes.
All our patients. Every single patient. So if it's a STEMI patient, our staff puts in full PPE, negative pressure cath lab, and we do it. If it's a non-STEMI, as you said, we defer, do the swab, and wait. Because if they are hemodynamically stable, no need to expose the staff. In fact, the problem is if one of your interventional cardiologists goes down, then your cath lab is 50% inoperable. So this is really a very serious resource utilization issue.
Yes.
It's very difficult now.
Dr. Hossam, please unmute. Unmute, ya Hossam.
Unmute, Hossam.
We have here two questions. The first one, can we add loop diuretics to avoid rise of potassium in concomitance with Eplerenone? This is the first
loop diuretics are used mainly to relieve symptoms of heart failure, to relieve the dyspnea, to relieve the volume overload. And when we reach a dry state, the patient is not in need for more loop diuretics, definitely we reduce the dose of these loop diuretics because of the hazards of these diuretics on the renal function. So we don't use the loop diuretics to minimize the hyperkalemic effect due to mineralocorticoid receptor antagonists. This is not the main reason to use loop diuretics. The main reason to use loop diuretics is to reduce the symptoms of heart failure, which are mainly the dyspnea, orthopnea, and paroxysmal nocturnal dyspnea, and to reduce the volume overload due to a heart failure, not to reduce the side effect of mineralocorticoid receptor antagonists.
Another question, the main rule for Eplerenone is to improve symptoms or to improve long-term mortality. So why not to give it for a patient with improved symptoms on the traditional treatment to improve the long-term mortality?
Actually, we have this trial. We have the reminder trial that patients with heart failure with reduced ejection fraction and they have mild symptoms, and definitely the prognosis was better with this patient who received Eplerenone as compared to placebo. And I think the future, the guidelines, the European Society of Cardiology guidelines, this was in 2016, and now we are in 2020. It's 4 years away from these guidelines, and these guidelines are changeable. Every guidelines has new recommendations, and I think this will be the future of the mineralocorticoid receptor antagonists, to use these drugs in patients with heart failure with reduced ejection fraction and mild symptoms, and even we can use these drugs, as Dr. Hany mentioned, in a patient with heart failure with preserved TOPCAT study.
Another question, Eplerenone has already a role in resistant hypertension as spironolactone or not?
Yes, because it has the same mechanism. Both of them are mineralocorticoid receptor antagonists, and especially in a patient with hypokalemic hypertension, both of them are effective in the treatment of hypertension, Eplerenone and spironolactone.
Another question, in the center I'm working in, we have noticed type 2 diabetes in COVID-19 patients with high CK, and there is no clear guidance or protocol in examining their comorbidities. What do you think?
Type 2 MI in COVID-19 patients.
Yeah.
Acute MI in COVID-19 patients.
Yes. Type 2 MI, sorry, not diabetes, yes. Sorry.
Yes. Definitely. Patients coming with chest pain and ST elevation in the ECG and troponin rise it is very difficult to differentiate between plaque rupture due to atherosclerotic coronary artery disease and plaque rupture due to the COVID-19. In this condition, I think we have to deal in a patient coming with ST elevation myocardial infarction as an ST elevation MI and should be treated in a such way. And later on, either you rule out or rule in the presence of COVID-19. And as Dr. Hany mentioned, that every patient coming to the ER with acute coronary syndrome should be dealt with as a COVID-19 positive patients until proved otherwise.
Okay.
They are asking about females with no problem with gynecomastia. Do you think that spironolactone now is good enough?
It is not the problem of gynecomastia, but it is a problem of the painful nipple.
So if you still have a female, do you still give Eplerenone rather than
no, the main side effect, in addition to gynecomastia, they have a painful nipple, which is a very pain. They have very pain in their nipples. And this is the main cause of stopping such drug. So gynecomastia is not a problem in female, but the pain in the nipple due to this gynecomastia is the main problem in female patients.
I think we answered this question. There is strong evidence of the use of Eplerenone in STEMI with ejection fraction more than 40. I think this question was answered.
I think this would be the future of this mineralocorticoid receptor antagonists.
Yes.
STEM remodeling, I think.
Okay, I think that we have to conclude this interesting session with lovely presentations and interesting discussions. I just want to thank all the contributors of this interesting webinar. Of course, thanks to Professor Hany Sabbour from the United Arab Emirates. معلش يا هاني سهرناك النهارده، انا عارف في فرق ساعتين.
لا ما نستناش ابدا.
فاحنا مبسوطين من وجودك معانا وشرفتنا، وفعلا كانت محاضره رائعه، وبنشكر طبعا استاذ دكتور نبيل فرج على المحاضره والاوفر فيو عن الكوفيد.
شكرا يا سامح. شكرا يا حسام.
Very interesting discussion. وطبعا قائد القعده كلها بروفيسور حسام حسن. Thank you very much for the interactions and moderating the session. وعندنا خبر حلو ان بكره ان شاء الله الساعه 12 at 12 p.m. Professor Hany Sabbour will be with us again at iHeart portal to answer more questions, sort of a private discussion with those who are interested in heart failure management and telemedicine. He's an expert in this regard. So 12 p.m. On iHeart portal, please don't forget. We will have Professor Hany Sabbour with us again tomorrow. And ما تنسوش الساعة 8 بالليل عندنا ويبينار نمبر 5، وده هيبقى مخصص للاريثمياز. معانا احمد ضماط، بروفيسور احمد ضماطي هيكلمنا عن how to interpret ECG. عارفين التأثير بتاع الهيدروكسيك كلوروكين على الاي سي جي، ازاي to assess the ECG in patients in COVID-19, what to look for, how to control pacemakers remotely زي ما الدكتور هاني ألمح إليها النهارده، لكن بكره بالتفصيل ازاي to control patients with permanent pacemakers and ICD. وكمان معانا الدكتور شريف الطوخي هيتكلم عن management of procedures, invasive procedures in the cath lab in the COVID-19. ايه الحالات الامرجنسي، وايه الحالات اللي ممكن نأجلها. كل دي معلومات مهمة جدا هنقولها بكره ان شاء الله في 3 important lectures الساعة 8 p.m. أرجو ان الجميع يكون معانا بكره.